My name is Albert Telfian, and I am a professor of neurosurgery at Brown University and the director of minimally invasive endoscopic spine surgery at Rhode Island Hospital. And welcome to my SMIS talk on endoscopic techniques and outcomes in endoscopic spine fusion. My disclosures: I receive an honorarium for teaching cadaver labs from JoyMax, and I'm a consultant for Integrity Spine. This is a 2016 Journal Neurosurgery Focus paper I published with my colleagues on the anatomic rationale for transforaminal endoscopic interbody fusion. This was a cadaveric analysis removing the facets at the lumbar disc levels and measuring the distance between the traversing and endoscopic, measuring the distance between the traversing and exiting nerve roots to determine whether it would be feasible to place a cage, static or expandable, through Camden's triangle. This is an example of Camden's triangle at L5S1. You can see the pedicle of S1 on the left and the pedicle of L5 on the right. And this is L3-4. The pedicle 4 is on the left. The pedicle of 3 is on the right. And this is the size of the safe zone between the exiting and traversing nerve roots. One thing not shown here is how in this diagram on the right, the facet can essentially occlude safe passage of a T-lift cage through Camden's triangle. The cage, you could see, would hit the superior articulating process and retract and possibly damage the dorsal root ganglion, giving the patient a permanent or temporary dysesthesia. These are the distances at the different lumbar levels between the exiting and traversing nerve roots, cranial and caudal, in Camden's triangle. And you can see it's quite similar at L1-2 down to L5S1. And these are the mean areas of Camden's triangle. So the size of Camden's triangle essentially gives us enough room to place a cage. This is me, a photograph taken during an endoscopic spine fusion. The patient is positioned prone on a Jackson table. The patient's awake. I'm only wearing loops for closing with a fluoromonochrome. I use fluoroscopy. This is a case where a patient had L4-5 foraminal disc herniation on the left, severe end plate changes with about 50% complaint of back pain and a 50% complaint of an L4 radiculopathy. The patient, you can see here, has that severe left foraminal narrowing. And this is a photograph of me with the ball probe. This is after the endoscopic decompression. We can see the pedicle on the right in the neuroforamen with the disc below. There's specialized instruments for disc prep. On the left is an expandable paddle shaver. On the right is a curette. And I've placed on the left, you can see the expandable titanium cage, and then placed the percutaneous screws using Marcaine. I do this as an outpatient procedure, so the patient goes home about an hour after the surgery. One thing I found that's interesting was treating deformity with endoscopic spine fusion. Here's a patient with severe degenerative disc disease at L4-5 and L5-S1. And patient had undergone a 2-level microdiscectomy by another surgeon and continued with radicular complaints and back pain. On the right, you can see the percutaneous screws placed, and at L4-5 and L5-S1, you can see I've placed a bone in the bag implant for an endoscopic spine fusion here. Now the arrows here are really to denote, you can see the change in the disc height that I've been able to achieve by packing the bone and then locking in the screws. What's interesting, post-operatively, you can see the patient, the x-ray on the left is the pre-operative coronal imbalance at these 2 levels, but intraoperatively, the final product, I've been able to reestablish that normal coronal alignment with those expandable cages. Also, quite useful is being able to use transforaminal lumbar interbody fusion with an endoscopic approach for salvage procedure. So here is a patient that had an L3 to 5 T-lift procedure and developed a pseudoarthrosis at L3-4. You can see that lucency in the top left panel. And the patient also has developed haloing around his L3 screw here. So the patient has a pseudoarthrosis at L3-4 and a loose screw. The patient has a complicated cardiac history and is not a candidate for general anesthesia. So in this case, we can see I've performed an endoscopic T-lift procedure. I've done an endoscopic discectomy parallel to the existing T-lift cage. You can see the expandable paddle shaver, placed a titanium cage, expanded this. These are endoscopic photographs, the discectomy with the endoscopic grasper on the left. I'm using the endoscopic drill to drill down that superarticulating process to let me navigate that titanium cage in safely. And on the right is a photograph of the expandable cage that I evaluate with the endoscopic camera to make sure it's not compressing the nerve at the end. The final product of that case is the patient has an awake T-lift and goes home with his back pain resolved. Outcomes for this procedure. Here's a recent paper from Ralph Wagner and Monica Hefner in Neurospine. And they reviewed the outcomes of endoscopic uniportal T-lift. And you can see on the right the number of patients in these series is growing. 18, 7, 45, 18, 69, 85. And you can see the operative times between 1 and 3 hours, and the improvements in VAS and ODI are significant. To summarize, I think endoscopic spine surgery today in 2020 is feasible, is being done around the world, and is very successful in the appropriately selected patient. Thank you for your attention.